Kevin did share our emails. So again, any kind of like tech or logistical questions can go to Kevin. And if you have any questions or comments, again, you can put them in the comment section, or you have our contact information as well. All right, so let's get back to the slides. Hopefully this is what I need to do. Let's see. Yes, all right, so moving on. So let's talk about this list of things. Feeling different, not being accepted, not being able to do something other people can do, moving to a new home or having a significant change at home, knowing that you're different from the people around you in some way, not feeling that anyone's listening to you or that anyone understands you, failing at a task. So this probably seems like a strange slide to have in a presentation about trauma, because this slide could have just been titled 7th grade, right? So why would we list things that are a part of life? I would be very surprised if any of you could look at this list and say, nope, I have never felt any one of these things ever. Why is this on here? Because this is a kind of trauma that is not about intensity. Let me give you an example. I want all of you guys to pick something on this list. Let's do the same thing. Let's pick failing at a task. Let's do that one. Here's what I want you to do, and I'm not going to ask you to share what it was, but I want you to take a second. If you're taking notes or, you know, checking work emails or whatever, put that down for a minute and just be present. And I want you to think about a time that you failed at something. And I don't mean like, oh, I guess water skiing's not for me. I mean like you really failed. Maybe it was something that was really important to you. Maybe it was something that other people saw you failing at. And I want you to connect to that experience and see if you can remember what that felt like. And my guess is if I could see you all right now, I would see a lot of you going like, that does not feel good. And if I then asked you, what did you do? Probably you guys would tell me some version of, you know, well, I felt bad for a while, and then I had people around me who helped pick me back up, or, you know, I found a new group of people to be around, or I practiced and practiced and practiced until I succeeded, or I found a different way, or whatever it is. And to be honest with you, I'm cheating a little bit because I already know something about you guys. I know, not having met any of you, that you are really good at not failing. The reason I know this is that you all have really important, responsible jobs. The work you do affects other people's lives. And so I already know that most, if not all of you, have pretty good strategies when you fail at something or if something doesn't come easily the first time. And I'm hoping that most, if not all of you, have a support system of people around you. People who will say, that's all right, you'll get them next time. I think you're the bee's knees. I don't know if any of the people in your life say that to you. I hope they do. I think bee's knees is definitely something we need to bring back. And my guess is those people, by and large, are not paid to be in your life. You may see a therapist, or you may work with this or that, you know, or a coach or something like that. But generally speaking, the people who know you and care about you are there naturally or organically, as we might say. Now I want you to look at this same list, and I want you to ask yourself how often the people we support, people with developmental disabilities, might feel some of these things. For some of them, it's every day, right? For some of them, it's multiple times every day. And depending on what age group you work with, one of the good things about the developmental disabilities field is that over the decades, we've been able to make big strides in caring for people medically. And a lot of folks have a much longer lifespan than they might have expected to have, let's say 30 or 50 years ago. So that's great news. The downside of that is that if you are an individual who's experiencing some of these things regularly, that might mean that day after day, year after year, decade after decade, your brain might be experiencing these stressors. And so going through it occasionally, or having a tough year in school or something, that's one thing, and probably won't create some of the changes that we see in the brain and body when people have dealt with trauma. But given enough time, enough repetition, And given the fact that a lot of the folks that we work with don't have the coping strategies and they don't have the natural support systems around them to bounce back from these stressors, means that given enough time, you start to see the same effects on the brain. One of my favorite slides in this whole presentation, Steve Click, I'm happy to say, is a friend of mine. He is a 30-year veteran, now a retired lieutenant from the Ohio Highway Patrol. And he does a lot of work now with first responders, law enforcement, folks like that, teaching them about trauma. And this is the way that he describes to them the difference between big T, that slide we looked at in the first hour with all of those catastrophic, life-changing events, versus the gradual impact of little t. Big T is like being attacked by a bear. Little t is like being attacked by ducks. And here's why I like that, because it's really easy when it comes to someone else, or especially ourselves, to dismiss a duck. Oh, it's not that big of a deal. I'm making too big of a deal of it. Who cares? And if it's one duck, yeah, okay. But given enough time and enough ducks, and it starts to look a lot like a bear attack, right? So when we think about, well, how often do the folks that we work with really experience trauma? We have to ask that question in a sophisticated way. We can't just look at big T trauma, which is what people usually think of. We have to also include the little t trauma. So when we're trying to figure out how many of our individuals are likely to have experienced trauma, what we need to understand is that various studies and researchers suggest that it's more than 90%. We know that if you have a disability of any kind, not just developmental disabilities, you are more vulnerable to some forms of big T trauma. You are more vulnerable to assault. You are more vulnerable to maltreatment. You are more vulnerable to financial exploitation, any of that stuff. Now add in the fact that if you are looking for someone to victimize, a lot of the individuals we work with, we're going to be ideal for that, right? Those folks that we work with are going to be ideal. That's why, for example, when you talk about things like human trafficking and sex trafficking, it's not as big a part of the conversation as it needs to be. I do see that changing. But we do know, for example, that when you look at people who've been sex trafficked, especially young women, many of them would qualify, whether they've been identified yet or not, probably would qualify as needing at least mild levels of support. We know that some of our folks have higher levels of social gullibility. They're easier to threaten and fool. If you tell anyone about what we did together, then you're going to go to jail. And when you look at the issues that we have in our field in terms of workforce, some large providers, large counties have a very fast rate of turnover, so that even some places it's like 50%, that the staff in a particular setting might have 100% turned over in the course of a year. So what that means is, if someone is there who is there to victimize people, they could be in and out before we even recognize what's going on. And that's not the only problem. The other problem is that, let's be honest, sometimes when our individuals try to talk about what's going on, they are dismissed, or it's sort of explained away, or, oh, you just want attention. Some of our folks are non-speaking, which of course makes it that much more difficult. There's another problem too, which is, even if someone reports something, and even if it's taken seriously and handled appropriately and believed, if this is an individual who, let's say, has moved around, who's gone from placement to placement or county to county, sometimes the problem is someone arrives and we know almost nothing about them. And sometimes the problem is the opposite. Someone arrives at our program or our county or whatever, and there are, what we used to use like milk crates of papers and files, and things get lost. So we know that this is a population with a high rate of vulnerability for trauma. We also know that that trauma is likely to go underreported. Again, I think we're doing better with this, but this is going to be, I think, the next big push in our field, is to try to be able to to identify traumatic and stressful situations quicker and to be able to respond to them better. There was a study, there was a study reported by NPR, and this was a few years ago. It was a small study, okay, so you can't draw big conclusions from it, but this study surveyed women with developmental disabilities and found that 90% of them had experienced some level of sexual trauma. 90%. So even if that turns out to be kind of an outlier and the number is a little bit lower than that, it's still way too much. So as I said at the beginning, we're not talking about trauma as if somehow it's different for someone who has a developmental disability in terms of how their brain and body works, but it certainly is different in terms of how vulnerable they are to trauma. And when we're talking with folks with developmental disabilities, we have to assume that if it's more than 90%, basically anyone that you talk to or work with who has a developmental disability is at high risk for having had potentially traumatic events in their life. That's the bottom line. Everyone you talk to, that's what you should start out assuming. Now we're going to come back to that in a moment, but I want to talk a little bit about, as I said, a tiny little bit about when someone has been diagnosed with PTSD, what does that mean? What did someone look at to give them that diagnosis? And what is going on in the brain and body when someone is confronted with a potential threat? So, actually, I want to talk about this really briefly. As we start talking about how common trauma is, people will sometimes start thinking about a couple of things. One is, wow, we need to do a better job of screening for trauma and look for those big T events in someone's life, which is true. We're going to talk more about that. But there's a problem and we have a solution for it. The other thing that happens is that people will start thinking about triggers. We're pretty aware of triggers. If you've seen movies or TV shows, you kind of know what that means, that someone was triggered. If you think about the story with my professor in the movie theater, that's how most of us would describe that moment when he heard or saw whatever he heard and saw on the screen and then leapt out of his seat and started screaming. He was triggered. There's a problem with this. And as a psychotherapist, I'm very familiar with this. One of the problems is that sometimes you can identify what a trigger is for someone. Like, you know, you might say to my professor, like, maybe no more war movies for you, right? Like that would just make sense. Or if I told you that I'd been in active combat in Afghanistan and I wasn't going to the fireworks on the 4th of July because that's too triggering for me, you'd be like, good idea, right? That's pretty obvious. Or in my example this morning, you may work with Kevin long enough to know that any petite, dark-haired woman with glasses is a potential trigger for him. And so at least initially, we might think, hey, maybe we don't give him any staff people that look like that. That's fine. But again, one of the problems is that you don't always know what triggers are. I work with people with extreme levels of trauma in my private practice, and sometimes they can identify what triggered them. Sometimes they can't. It's almost as if, and this is especially true when we're talking about more extreme forms of trauma, sometimes it's like an alarm system that sets itself off. So if you go on this like goose chase for identifying all the triggers, you probably aren't ever going to be able to identify all of them. But that's not even the biggest problem. The biggest problem is that trauma, when it has been severe enough, early enough, or chronic enough in someone's life, can start to affect everything about who they are. Trauma can affect how aware you are of your thoughts, feelings, and sensations and where your body is. That may sound very odd to you, but a little bit later today and in our training tomorrow, we're going to talk more about this, that if you've ever heard the term dissociation, you probably think of things like someone waking up going, where am I? I'm in a new city. What happened? And in very, very extreme forms of dissociation, you can have that happen. Or things like dissociative identity disorder, which people used to call multiple personalities. That's pretty rare to have someone with that level of dissociating. Dissociating really just means two things that are usually together, that are associated, have come apart. And there are much more everyday examples of this that happen to all of us. So for example, let's say you're driving home, and if you've got, let's say there's a decent drive that from work to home. Let's say it's a, I don't know, 20, 30-minute drive, and you do it twice a day, every day, you're very familiar with it. You've probably experienced that you've been thinking about, an argument you had at work, or this great training you went to today, or whatever, or you're singing along to the radio, and you suddenly kind of look around and realize that you haven't been paying attention to your driving at all, because it's so automatic for your brain that you can separate your attention and still do it. Okay, that's something that probably all of us have experienced at some time or another. Another version of this might be when someone has separated the feelings from their words. Now, in developmental disabilities, we sometimes work with people who have low affect for other reasons. So folks who are on that autism continuum, for example, may sometimes have less expressiveness. So it may just seem like they're not feeling as much. That's not true. We just can't see it as easily. When I work with someone who's had trauma, the dissociation that I will sometimes see is they can talk about horrifying events without any emotion whatsoever, and they'll describe it as having no emotion. They'll describe themselves as feeling numb. So, for example, I worked with someone once I do some work in the refugee community, and this person had been tortured in their home country as a political prisoner. They came in for a session. I think I started with, "How are you?" I would never have started with, "Let's talk about what happened." And he just, as if he'd hit a play button, he just started reciting what had happened. And he talked about things so horrifying that I had a hard time not crying listening to him. His face was completely expressionless. It was as if he was reading a list of groceries to me. So that's a common example of when the words and the feelings, or the thoughts and the sensations, or whatever it is, have separated. We're going to talk more about dissociation in a minute. My point here is just that if that happens to you intensely enough, often enough, you walk around for a good part of your life not feeling very much. I read an interview with a veteran, I think of the first Gulf War, who said, "Before I went overseas, I had a normal range of human emotions, and when I came back, I had two feelings: numbness and rage." So that can start to affect how you are all the time, how you are with other people. Remember when I talked about young people who've experienced high levels of trauma may have that same kind of emotional shutdown, and you can't empathize with how someone else is feeling if you're not feeling anything. We experience empathy by seeing someone's facial expression, maybe even pheromones. We don't really know. And we, in a microsecond, we kind of bounce that off of our own feelings, right? And we go, "Oh, there are tears coming out of their eyes, and their mouth looks like this, and they're doing this. I think they're sad." That happens so quickly for you that you're not aware of it, fractions of a second. But now imagine that there's nothing going on in here. There's nothing to bounce off of. You don't feel much about other people's feelings, which is why someone with intense levels of trauma can start to look sociopathic. Again, that's not to say that some of them aren't actually sociopaths. It just means when we don't treat trauma, people can look really, can look like they have diagnoses that they don't really have. Okay, I could go on and on about this, but just briefly, how quickly you react, how quickly you can think, how you judge the intentions and actions of others. Again, if any of you work with teenagers, you will know exactly what I'm talking about. There are a lot of kids who walk through the world with that hair trigger. This is true of adults too, of course. Many of you have worked somewhere where someone told you ahead of time, "Hey, listen, when you work with Lara, just, make sure that you don't come up behind her and put your hand on her shoulder, because I'm gonna, what? I'm gonna turn around swinging, right? I will have hit you long before I stop to look at who it actually was." Someone with that hair trigger who has hit someone or thrown a chair or stormed out or done whatever, long before their thinking brain has had a chance to catch up and accurately assess what's going on. Another example of this, as I said, from our example this morning, Kevin seeing a dark-haired woman with glasses, boom, right? Or someone who's run out the door or shut down sobbing, or they're completely checked out, or whatever it is. How quickly and accurately you respond to your own environment. There were so many young people where if I could have bought them 2 seconds of time before they threw that punch or threw that chair or got into that car, whatever it was, their lives would be so very different. How much you can ever relax in your own skin. We're going to talk in a little bit about hyperarousal, and really that just means, and hypervigilance. you're always on red alert. You're always tense. If I'm that individual that you can't put your hand on my shoulder because I'm going to turn around and punch you, part of that is I am always revved up and ready to go, ready to bolt out the door. For people with developmental disabilities who have those like hard to pin down health issues, some of that might be chronic levels of hypervigilance. They are constantly wound up. That will do a number on, I'm going to go back to the next one, how I sleep, how I digest my food, how I fight off disease. If I have chronically high levels of stress, we know that that can lower my immune system. It may play a role in being the on switch for some genetic diseases. So for example, there's some autoimmune disorders that we think high levels of stress may contribute. If I've already got in my genes that I'm vulnerable to this illness, I don't know, let's say rheumatoid arthritis, and I have high levels of stress in my life, that may be one of the things that kind of turns on that switch. Obviously, this is not to say that everyone with an autoimmune disorder has trauma or that it's anything that simple, but that is absolutely, for some folks, a factor. Sleep is a huge issue. Think about how many folks you've worked with or known or whatever, where there's a constant battle about sleep. They don't want to sleep in the day at night. They want to sleep in the daytime, and they want to be up all night, and they don't want to sleep in their room. They want to sleep on the couch in the living room or the staff office or whatever. Well, there are a couple of things to consider with that. Number one, there are a lot of people who cannot relax enough to sleep in a bedroom because that's where some bad things happened. So for my money, if they need to sleep on the couch, they sleep on the couch, right? Like I don't know why we get into huge power struggles about that sometimes. The other issue that can be trickier to pin down is that chronic stress can mess with my brain's ability to get down into those deeper brainwave states that will let me fall asleep and stay asleep. In fact, in my practice, problems with sleep and problems with emotionally connected sex are often two of the earliest things that people notice that might bring them into therapy, which makes sense, right? You've got to feel deeply relaxed to be able to do either of those things. So some of the folks that you work with may have difficulty with sleep, or they have disrupted sleep because of chronic exposure to stress for their brain and body. How well they digest food. That's a huge thing as well. When I'm under stress, my tummy's not feeling great, right? We won't go into more detail than that. But there are times when I think we're treating those folks, again, if they have a developmental disability, like they're trying to make our shift difficult, or they just want attention from the nurse, but nobody's been able to diagnose a stomach problem or that headache or the teeth grinding. And what we may be seeing are folks who are having what therapists call somatic symptoms, symptoms of emotional stress that are expressed in the body. So it'd really help if we stop just dismissing them as attention seeking. Number one, all human beings need attention. I love attention. Notice what I do for a living, right? And there may also be some folks who are experiencing somatically distress that they don't talk about or experience as emotional issues. Make sense? Now, let me say this. A lot of the folks you work with also do have complex medical things going on. So you may have an individual who has GERD or stomach upset because of whatever syndrome that they've got, or they take medication that's hard on their tummy. I'm not saying everything is trauma all the time. I'm just saying that if it's true that perhaps upwards of 90% of the folks we work with also have significant levels of traumatic stress, trauma will certainly not make any of those things better and can very easily make many of them worse. Okay, so remember we started talking about triggers. The reason why you don't want to just focus on identifying my triggers if I'm your individual is that you'll miss the boat, you'll miss the bigger picture. I sometimes think of trauma as like seawater, okay? So if I'm a ship, I'm out on the ocean and I've got leaks and there's seawater coming in, that seawater might start from a particular place, but eventually it will seep into every corner of the ship. And enough of it, it'll sink the ship, right? So it's not, you can't just clear out one part of the ship. You need to deal with all of it, okay? Okay, I'm paying attention to our time, so I'm gonna jump ahead here. Love to talk more about that stuff, but basically I'd like to have weeks with you guys, and we're just gonna smush this into 2 days. 2 mornings really. So I love this quote. Michael DeBellis is probably a name you don't know, but he's done a lot of work with some of the more famous folks in trauma, like Vander Kolk, Bruce Perry, if you work with kids. I loved what he said about children, but this is true for adults as well. There are infinite causes of trauma, but finite responses. There are only so many ways that you can deal with overwhelming stress. We're going to talk about those in a minute. Trauma is worse for kids than adults neurologically. We just know this, and it makes sense. 0 to 3 is the most vulnerable time for a developing brain to experience overwhelming levels of stress and fear. 0 to 7, really. Now, that doesn't mean that someone who's an adult can't experience brain change because of overwhelming levels of stress. They absolutely can. But it's kind of like the difference between, I don't know about Pickaway, but in Columbus, we got tons of rain last week, and my dog would run across my backyard and it just tore everything up. The ground was just saturated with water, so it was really easy to churn up the mud and the grass. We've had a few days that have been really dry, and now it's much harder to do that. So it's kind of like when trauma and stress happen to a young brain, it's just easier to kind of leave that mark, right? Some levels of stress may actually change the size of regions of the brain in young children, which is bad news. For adults, it's harder. So adults tend to be a little more protected from brain change if trauma starts later in life. The reason I'm going into such detail about this is I can't tell you the number of times we've worked with a provider or a county or a state or whatever, and someone has been talking about an individual, and they might say something like, oh, well, we found out that Laura was being abused by her birth parents, so she was placed in foster care with the grandmother, but the grandmother drank, so they had to move her around, and she was in 4 different placements by the time she was 5. But she doesn't remember any of that, so we don't think she was traumatized. Wrong. Whether I have a conscious memory of events or not is really beside the point. The younger I am, the more damaging that stress can potentially be to my brain. So it's really important to know that just because someone doesn't remember it doesn't mean that somehow it's not as impactful. And the last one I think is really important too, to say it simply, when we've been harmed by another person, it's much worse for us than if we've been in, I don't know, like a car accident or, a mine cave-in or something like that. And it makes sense for why. As we talk about the brain and body, we'll go into how important it is for human beings to feel connected to another human being. We are born as infants needing that connection. If you've ever known someone with a child in the hospital, like a preemie in NICU or something like that, that skin-to-skin contact with that infant and the mother or the father is now much more medically emphasized because babies heal faster, develop faster, put on weight faster when they have a lot of skin time with that loving adult, right? Our brains absolutely need to be connected with other brains, especially as we're developing. So if the thing that I need to grow and thrive and feel safe is the thing that hurt me, then it's sort of like all food has been poisoned. Where can I ever find food that I feel safe to eat again? So imagine that terrible dilemma with trauma. If I say to you that you need to work with me and trust me and build a relationship with me so that we can work with your trauma and work with your skills and help you handle things differently so you're not punching people or whatever, what I'm really saying to you is that poison that made you sick, now it's the medicine. So maybe it's not so surprising that many of our individuals take a long time to trust people and to start to build those relationships. Okay, so I'm going to talk briefly about these and then we'll wrap up with a little bit of brain time. When we talk about someone having a diagnosis of PTSD, there are 4 groups of symptoms that someone will kind of check off. And if someone has enough symptoms in enough of these areas, then they would qualify for that PTSD diagnosis. We're not going to go through this in detail because you guys are not doing this training to diagnose it, but I want you to be familiar with what someone looked at if they gave someone that PTSD diagnosis. The first one we've already talked about a lot, that's hypervigilance. It just means that you are constantly on red alert waiting for something to happen. And as we've talked about, That's exhausting. That does a number on someone psychologically. It often causes a lot of the physical problems that we see, because it's like your body is just flooded with adrenaline all the time, which it's not meant to be. The next one, avoidance. This just kind of makes sense. If any of you were around in the DSM-4 years, you might have seen this as constriction. It really just means that you are making yourself and your life smaller and smaller and smaller to try to avoid being triggered. So instead of being a veteran who doesn't go to a fireworks display, I don't go to big parties, and I don't go to barbecues, and I don't go to the mall, and I don't go to Walmart unless it's 4 a.m. And pretty soon I don't leave my house. My world gets smaller and smaller and smaller and smaller to try to control being triggered and trying to avoid it. We will often see this in terms of rigidity with some of the folks that we work with. If I rely on routine, and people who've experienced trauma often become very reliant on things being very predictable. Otherwise, it kicks off our hypervigilance, right? So I'm used to the fact that on Tuesdays, we're going to have pudding. And this Tuesday, we had applesauce instead of pudding, and I flip out. It's really easy to be like, ugh, why would she make such a big deal about pudding? It's not about pudding. It's about life feeling safe and predictable. And one of the problems with avoidance is that it really cuts down on my ability to be flexible. I can't take a different way to work. I can't meet new people. I can't try new things because I've made myself as small as possible. See what I mean? And this is also why things that may look like something else can actually be trauma. So for example, we know that many folks on the autism spectrum may also have some of that rigidity and reliance on routine. Fair enough. It's easy to say all of that is autism and not pay a lot of attention to some of it might actually be trauma. And if someone gets help with trauma, some of that rigidity may loosen up a little bit. Intrusion, this is the one that I think people usually think about when they think about someone with PTSD. So this is things like flashbacks. My professor screaming in that movie theater, that was intrusion of a flashback. Someone who has nightmares, intrusive thoughts. I had a girl tell me once that she'd be sitting in math class and she was like, I wasn't thinking about my abuse, I was thinking about math. And then suddenly there was a disgusting movie in my head. Interestingly, dreams and nightmares are one of the few, special trauma symptoms that we can actually directly treat with medication. We can't at this point treat PTSD itself with meds. We can manage symptoms like depression and anxiety. We can also treat nightmares with a medication called prazosin. Some people respond to it, some people don't, but that is actually really helpful if we can help someone deal with nightmares. And then finally, negative alterations in cognition and mood is a really boring, dry way of saying this can leave people vulnerable to depression and anxiety, and it changes how they see themselves and how they see the world. Yeah. So that's when someone's been diagnosed with PTSD, they had enough symptoms and enough of those categories to qualify for that diagnosis. That's what someone was looking at. Okay. I'm not going to spend time on these. The biggest thing for diagnosis of trauma in someone with a developmental disability, and again, this training is not so you guys can run around diagnosing people, but just to be aware that the less someone speaks, the harder it is to assess some of these things, because a lot of those diagnoses require some kind of self-reporting, right? Someone can say, I'm tense all the time, or I'm having terrible nightmares, or the thought of being intimate with someone makes me want to run out of the room, stuff like that. The less that someone speaks, the more they will show us what's going on. In fact, I've always hated the phrase acting out. Laura's acting out. Oh, I just hate it. I would like it much better if we could add one word to it. If we could say, Laura is acting it out, or Laura is showing us what it feels like inside. Okay, so, and I would do the same thing with someone saying, Laura's having a behavior. I have no idea what that even means. If you said, Laura seems to be distressed, and it's showing up in her behavior of screaming and throwing a chair at me, fair enough. But when someone has a developmental disability, the more they are impacted by that disability in terms of expressing, the more we will see it in their body, whether that's through their behavior, their actions, or we may see it in terms of things that indicate physical pain or distress. So we have to pay even closer attention to things that I might be doing, like rocking or hand wringing, or if I'm having a lot of headaches or stomach aches or whatever. That's also true for the general population, by the way. It's estimated that about 30% of us, just in the typical population, will tend to express emotional distress more in our bodies. So we may not identify it for ourselves as anxiety. We may know that we're having a lot of headaches or that we're having a lot of, tummy troubles or whatever. But especially if someone has significant levels of impact from a disability, where we have to look visually at all of those nonverbal signals. Okay, so brain stuff, yay, yay, yay. Now, I'm going to tell you a little bit about the brain, and then I'm going to tell you why some of the stuff isn't really the way we think about the brain anymore. And if you're interested in what we've been talking about today, I do have a book coming out that I'll tell you about a little bit more tomorrow, where I discuss this. Suffice it to say that talking about the brain in terms of this area does this and that area does that probably doesn't really fit in terms of really accurately describing how the brain is organized. It seems like the brain is organized more like, as one author put it, a network of airports around the world. And if there's, maybe the flights usually go in a predictable pattern, but if there's a hurricane or a snowstorm, then the flights can be rerouted much more easily than maybe we used to think. I'm still going to talk about areas of the brain doing certain things because those areas normally are very involved in those things. So we might say, this is the typical flight pattern, but if there's a change in the weather and things need to be rearranged, it can easily do that, okay? So one of the ways that I teach this is sometimes by having you guys do this. So raise your right hand, curl your fingers around your thumb, and see how this makes kind of a fist here. This sort of reproduces how we think about the major regions of the brain. So your wrist, your brainstem here, this mostly controls body function. And we used to sometimes call this the reptile brain. So if you think about all the things a reptile can do, they can run around, they can be still, some of them can run upright, they can digest food, they have a very basic, this is dangerous, this isn't, I'm going to run away, or I'm going to bite, or I'm going to freeze, or whatever. They can digest their food, they can poop out their food. I'm the mother of sons, so talked about poop a lot. And they can make little baby reptiles. That's pretty much it. That's what they do. So this part of your brain, much of the time, is concerned with those basic body functions. You don't have to consciously direct it or control it. It just kind of does it on its own. The middle layer, or where your thumb is sort of in the middle of your fist, this is sometimes called the mammal brain because we see this part of the brain bigger and more developed in mammals. This brain has a lot to do with linking senses and memories. So, if I smell like something burning, that might be associated with danger. Cookies, I associate with my grandma's house, and that's comforting, whatever. This also is where what we think is a lot of the alarm system of the brain tends to be centered. So specifically the amygdala, which you've probably heard a lot about. In our hand brain, if you could imagine two little almond-shaped freckles at the bottom of your thumbnail, that's about where the amygdala is. The amygdala is sometimes described as the smoke detector of the brain. So if there's something in your environment that seems like it's potentially threatening, your amygdala is going to send the signals that go through your brain and body to get you to react quickly to it. Imagine you're out walking around and you glance down and you see a snake right by your foot. What would you do? You'd probably, you'd be startled, you might freeze, you might jump away from it. And then you look a little more closely, you glance down again and the snake doesn't seem to be moving. And in fact, a little bit down on its body, it seems to have some leaves attached to it. Well, it turns out that what you thought was a snake was actually a stick. Your amygdala very quickly took in some sensory information, a couple little pieces, like brown and squiggly maybe, and went, oh, it's snake. And it got your brain and body, mostly the middle and lower brain all the way down to the body, to react, to jump, or to run away or whatever, to go, ah. Now, when you took a second look at it, Then you started to get the top brain involved. So this is like the back of your hand and the backs of your fingers down to your fingernails. And this is sometimes called the primate brain, or a better way to think of it is the cortex. Okay, so we have the brainstem, the limbic system, and the cortex. And the cortex is largely involved in what we tend to think of as those executive functions, especially in the front. The back is more involved with sensory things like hearing and seeing. The front especially is involved with thinking and choosing behavior and imagining consequences and things like that. So the cortex also talks to the limbic system and tries to put pieces together to reach a more detailed, sophisticated conclusion. So your brain looked down a second time and your cortex said, there are leaves attached to that snake and it seems not to be moving. I think that's actually a stick. We probably don't need to run down the street screaming. So, and again, this happens in fractions of a second, but you take a second look and you go, oh, silly me, it was a stick. And maybe your heart, is still fluttering a little bit, but you take a breath and calm down, right? You don't go, with a, big machete and chop up the stick, right? You're able to choose appropriate responses. So the limbic system is more about reactions, get me away from this dangerous thing. And the cortex is more about responses. What's the appropriate response? So one of the reasons, for example, that many of the teenagers that I worked with had problems with impulsive behavior, they would throw that punch or throw that chair or, whatever it was, get into that car before they'd have time to think it through. Some of that is because the front of their brain, especially the back of the front, if you're interested on the left side, seems to be involved with things like choosing behaviors and imagining consequences and impulse control. I may want to stay up all night partying, but if I know that I've got this training at 9 a.m. in the morning, I know that it's probably going to get me a better outcome to work on my slides and get to bed early. I'm able to choose the more effective strategy, partly because my brain has more developed brakes and can slow me down. Teenagers have a harder time with this. And trauma can also affect those things, which is why we may see people with an overactive alarm system largely functioning in the limbic system in the middle, and they get the slightest hint that there might be danger. So dark-haired lady, glasses, and they react. They've thrown that punch, or they've run out the door, or they've collapsed on the floor, and now they're in a fetal position long before the rest of the brain can kind of join the conversation and go, wait a minute, that thing with that dark-haired lady, that was years ago. And this woman, Lara, doesn't actually look that much like her. And I think maybe Lara's not dangerous. Let's wait and see. That person, Kevin's already punched me or run out the door or whatever, long before those things have happened. So when we're talking about someone who is, especially someone who is in that, what we call a hyperarousal state, and arousal here just means how activated is my nervous system. If you look at this slide, which is my first slide with shapes and colors that I ever made myself, so thank you very much. If you look at that, what on my screen looks like sort of that white band in the middle, that's where most of us spend most of our time. So you're awake, you're activated, you're paying attention, or you're completing a task, or you're doing whatever, and your heart rate and your breathing are all sort of within normal ranges. That's what we sometimes call in therapy a window of tolerance. And let's say something happens. Let's say you're watching this training sitting out on your porch today, which I hope some of you are doing because it's a nice day. And you hear rustling around up in the tree. You probably don't drop your laptop and run screaming down your driveway. You might glance up and you notice that there's a squirrel kind of rummaging around up there, and you go, squirrel. And you go back to paying attention. That rustling around, that tree sound was within your window of tolerance. You might attend to it because it's a new piece of information that wasn't happening before. So you look at it, you assess it quickly, not dangerous, you assessed it accurately, and you go back to what you were doing. Now imagine that I was a veteran of jungle warfare in Vietnam. I hear something rustling around and I have dropped my laptop and run screaming down the street, or I've frozen so that I can't be seen by a sniper, right? What happens to me in those moments is I may experience that and I go into hyper arousal. So I go up into that red zone. That's when everything is trying to mobilize me to get away. This is what we think of when we think about flight, fight, freeze, fawn, which we'll talk more about. You guys mostly probably think of it as fight or flight. It's that adrenalized, activated, I'm ready to run away or I'm ready to fight off whatever this threat is. So that's hyper arousal. We're just in a higher state of autonomic arousal than we normally are. It makes sense. Now at the bottom, that blue zone is exactly what you think it is. Instead of getting wound up and ready to fight, I'm collapsed. I'm shut down. I'm dissociated. I've checked out. We're going to spend more time tomorrow. We'll start here and talk about what it actually looks like for folks when they are in that state of hyperarousal, what it's like in their body, what happens emotionally, and what might be happening in their thinking. And we'll talk about what's going on when someone is in hyperarousal and they're limp or numb or checked out. And then we will use that as the springboard to talk about trauma responsive care. What do we actually do when someone is hyper-aroused or hypo-aroused? How do we work with the brain and body to get them back into that window of tolerance where their brain can function the way it normally functions, whatever's normal for them? So whatever my normal ability to talk or to explain how I'm feeling to you, or to control my impulses, or choose among different courses of action, we want to get me back into that window of tolerance so that I can respond appropriately to what's going on, rather than overreacting in hyperarousal or shutting down in hypoarousal. So that seems like a good stopping place for today. We'll pick back up with this slide tomorrow. I'm going to pause that share and I'm going to go to the comment section. Okay. As we wrap up today, I think it's also important to point out that I've started with developmental disabilities in terms of some of what we've talked about today, because I think that is the population where we really, we seem to have the most trouble in terms of identifying what is going on. But whether, as I've said throughout the day today, if you're working with kids or you're working with the general population, all of our brains and bodies are set up to work the same. So the general principles that we're going to talk about, I will continue to frame at times in that DD perspective, but it's based on the assumption that all human beings are basically built the same. Some people may have more challenges in terms of how they explain what's going on, and some people we may see a little differently, but a frightened brain is a frightened brain. And for me, I think that's the most important thing to start with as we talk about this. So I want to give folks another few minutes to see if we have any comments or questions. And again, also, if you have your own professional experiences or things that you want to share that kind of add to how we're talking about things, that is always really helpful as well. So give folks a moment here, and no, it looks like we're good. So I'm going to go ahead and toss this back to Kevin, see if there's anything else that he wants to talk about before we let you guys go. And thanks so much, you guys, and we'll see you tomorrow.